What about, just shifting gears a little bit, about the Del19 story, that the afatinib seemed to show a survival advantage in the subset analysis from the Lux-Lung 3 and 6. To my knowledge, it's the only survival advantage we've seen. Wasn't an intent to treat population. This was a mutation that some say is predictive of, it's quite sensitive no matter what TKI you give. Are people using afatinib in a Del19 patient based on that data? Didn't seem to shake out in the Lux-Lung 7 data, by the way.
Yeah. A lot more than are giving Bev with erlotinib. But you know what the amazing thing though, the paper from that Jeffy versus afatinib trial just came out. I asked you to look at the waterfall plots in that. It's very odd. The waterfall for Jeffy and afatinib in exon 19 is identical.
Yeah, they didn't
it's
figure
identical,
out. Yeah.
which is really unusual.
Yeah.
I'm Mr. Subgroup Analysis. We all make our living by doing these things, and most times we say, oh, it's a subgroup analysis if it's not yours. So it's hard to say. I mean, I find that whole trial actually that Sarah was talking about a little, tough to know how it changes practice. My gut actually would probably be to give afatinib, actually.
Okay. TKI of choice, Chandra?
Erlotinib.
Erlotinib?
We have the maximum, I guess, we have used it for a long time, and we have been able to treat all these patients, and the patients are comfortable, the physicians are comfortable, the investigators are comfortable, and the nurses are comfortable. Okay. So I think for me, the choice is still erlotinib. And though afatinib was better than gefitinib in that randomized trial, we really could not say that it is better than erlotinib.
Mark, do you give afatinib and bevacizumab in Del19?
I haven't. I haven't made that switch yet, but I intend to. I actually do. So we're going to have that osimertinib erlotinib trial, osimertinib bevacizumab. So that's going to be my first choice.
That will be first line.
Yeah.
So let's move on and really tackle this in terms of the treatment continuum for a patient. A patient receives EGFR TKI up front. We know eventually at some point their tumor will grow, there will develop progression. I would just make the comment that progression in this setting is heterogeneous. Not all progression is the same. I think we have to consider oligometastatic progression versus overall disease progression, factoring in whether a patient is symptomatic or not, and factoring in the potential presence of T790M. So Marina, can you just talk a little bit about your approach to treatment beyond progression and how you manage progression, and also, what lesion do we re-biopsy if we're heading towards a new treatment for that patient?
Okay, thank you. So what we know is that after about 12 months, more or less 50% of patients progress, and they can progress with the oligometastatic, with the oligoprogression, and in this case, we try to squeeze all the benefit of the EGFR TKIs, whatever you use. In Italy, we use according to the toxicity profile. So, for example, we avoid to use afatinib in old people for the toxicity. We would really like to use erlotinib and beva. But if you have a slow disease without symptoms and the progression is low, you try to use the EGFR tyrosine kinase inhibitors until you really can. What we do in our center is try to also to monitor the T790M, but in reality we don't know the real significance of monitoring the T790M, although we have the third generation EGFR TKI. When the disease, the burden of the disease is very present, we re-biopsy the patients, or we try to do a liquid biopsy. But in general, we prefer to re-biopsy the patients because the way in which the progression can appear, the pictures are very heterogeneous. And it's true that in the 50–70% of cases you may have the T790M, but you have 40% of cases in which you may have the epithelial mesenchymal transformation, the small cell lung cancer transformation. So I think that morphology is still important. Then you can test also for MET, for HER2, for all the mechanism of resistance. What we biopsy? We biopsy, which is more simple to re-biopsy. So we don't differentiate the primary from the metastasis. We just discuss in the multidisciplinary team, which is the easiest to re-biopsy, and we re-biopsy again. And then the story of the T790M is quite intriguing, because we started to think that it was a secondary mutation, but now I think that we are coming back because we can find it also in 30% of the metastatic EGFR mutated patients. So I think that maybe in the future we will have an EGFR T790M mutated disease and the T790M negative disease, and maybe we will select the treatment according to this.
How do you manage oligometastatic progression? So you haven't made that decision yet whether you want to re-biopsy or not. Are you addressing that local site with aggressive measures and riding out the TKI? What is the treatment approach in Europe been?
Well, we discuss in the multidisciplinary team what to do. I think that this is really important, because, for example, if you have just a bone metastasis, you can do radiotherapy, or a single brain metastasis, you can give radiotherapy. But maybe if you have a liver metastasis in a good segment, maybe you can re-biopsy at the time. So I think that the multidisciplinary team can help you on the decisions.
And then if you're, let's go through a not uncommon scenario. You do the biopsy, you've decided to do the biopsy or the plasma. Mm-hmm. It's T790M negative. There's no other actionable mutation within that biopsy. You institute chemotherapy, and what would be your chemotherapy choice, and would you continue the TKI when instituting the chemotherapy?
So, well, when we try to find T790M, MET, HER2, and if we don't find any actionable mutation, we go to chemotherapy. The most used regimen in Europe is cisplatin pemetrexed, differently from US, I think.
I don't think it's that different. I think we all have competing standards here in terms of what we use, but that would certainly be, I think, a consideration in the US as well. Any other thoughts in terms of managing progression and perhaps tips or nuggets of information on how to optimally manage progression?
We would probably tend to continue in those cases where we don't find another target. We would continue the current TKI until the chemo is kind of taken hold.
Right.
And then we'd probably stop the TKI.
Yeah, I think that's been the message here. I think you've taught me this, to really, when you are going to give chemotherapy, when you decide to give it, the TKI can come off, but not until the chemotherapy is really instituted.